Thank you so much for the nice introduction. So, good morning, everybody. I'm actually standing here on behalf of Dr. Miriam van der Burg. Unfortunately, she could not make it, but she sends her best regards to everybody here. So I would like to talk to you today about newborn screening for Skit and how it's actually more than just introducing a new assay in the lab. And I actually want to focus on a main ethical dilemma that we actually encountered in the Netherlands. So a little bit of background about newborn screening for Skit in the Netherlands. Just in Bobby's presentation, you already saw a big thick in the Netherlands. That's not completely true. I think it's more of an intermediate thick at the moment, because we are still screening in the form of a pilot study. And that pilot study is actually called the SONET study, as you can see here. And the SONET study is a prospective implementation pilot, and we are screening in 3 provinces of the Netherlands in 2 screening laboratories. So the pilot actually started in April in 2018, and it was planned for about a year. But then again, this year we had a re-evaluation and the pilot was very successful. So our Dutch Ministry of Health actually decided that already newborn screening for Skits should be fully implemented in our newborn screening program. So this will happen in October 2020. So until 2020, we are still screening in this pilot phase in 3 provinces of the Netherlands. So far we screened over 100,000 newborns, and unfortunately we have not identified a Skit patient yet. So maybe we need to do some adjustments in our incidence, but we will get there probably. So as you all know, newborn screening for Skit is based on the detection of T-cell receptor excision circles, or TRECs, and TRECs are a marker for T-cells. So if you have an abnormal TREC result, in this case a low TREC result, this will not automatically mean that this is a Skit patient. It will mean that your patient or your newborn has potentially Skit. But there are also lots of other diseases that can present at birth with low T-cells. And that is why you actually need a dedicated follow-up program. So as you can see here, what we do is within 72 hours after your newborn screening result, you will get a referral to your pediatrician. And at the pediatrician, of course, the first step will be immunophenotyping. So in that scenario, you actually now have 3 different ways that you can go. Either your newborn with an abnormal TREC result has actually normal T-cells. This will mean that it is a false positive screening result and actually no follow-up will be initiated. You can also have the very definitive case of absent T-cells. In that case, we would do genetic analysis, but we would also start with your pre-stem cell transplantation workup. And then you have actually the biggest group. So that's the newborns who have low or abnormal T-cells, but the T-cells are not absent. And I would like to go into this group in a bit more detail. So what are these children? Well, we call them the incidental findings of newborn screening for Skit, or sometimes also known as secondary findings. And you can actually distinguish them into 3 big categories. So you either have your idiopathic lymphocytopenia without an underlying cause, or you have your T-cell impairment syndromes, I will come back to those later, or your T-cell impairment secondary to other neonatal conditions. And other neonatal conditions are, for example, vascular leakage with sepsis, or the maternal use during the pregnancy of immunosuppressants. So T-cell impairment syndromes, I think many of you know them. Examples are, for example, DiGeorge syndrome or Down syndrome. But I would like to focus today on a specific disease named ataxia telangiectasia. So ataxia telangiectasia, it's actually not a very definitive immune deficiency. It's a neurodegeneration disorder. So it's a defect DNA repair disorder that is caused by a mutation in your ATM gene. And it's actually accompanied by a broad scala of different symptoms. You can either think about ataxia, but also a predisposition to malignancies such as leukemia, and also, in this case, a variable immunodeficiency. What is actually also remarkable about ataxia telangiectasia, or AT, is that if you are a carrier of the mutated gene, that you will also have an increased risk of breast cancer. So why is ataxia telangiectasia actually an extraordinary secondary finding to newborn screening for Skit? This is because it's not only an untreatable disease, but it's also a disease with a severely decreased life expectancy. So patients with the classic form of AT, they will not exceed the age of 30 years. There's actually a lot of discussion if early detection of AT has a significant improved health benefit for the child, which is also different from, for example, DiGeorge syndrome, in which case you would start with prophylactic antibiotics. And finally, the carriers of the ATM mutation, as I just explained, have an increased risk of cancer as well. So this would actually mean that you are participating in newborn screening for Skit, but the outcome is that your child not only has a very severe disease called AT, he will not live until the age of 30, and also you yourself as a mother have an increased risk of cancer. So the screening criteria, the Wilson and Jungner screening criteria, state that you can only screen for treatable disorders. And the Dutch Health Council actually agrees with this, and they stated in 2015, incidental findings should always be avoided when possible. Only clinical relevant, actionable incidental findings should be reported. And this is actually where we came into a big ethical dilemma, because would you consider AT an actionable incidental finding? It was actually quite a big discussion that we felt with multiple disciplinary teams. And in the conclusion, we said, well, okay, no, we don't think this is an actionable disease. We will exclude ATM from our follow-up Skit gene panel. So this means that AT cannot be a secondary finding to newborn screening for Skit. Unless there is a stem cell transplantation indication, you have no known underlying defect. In that case, you should always first exclude AT, because you do not want to start with your conditioning regimen in your AT patients. This is, of course, what we thought. But then we thought, well, maybe, there's more to this. There's different advantages and disadvantages in this case. And we as healthcare professionals actually could come up with this view. So an advantage of early diagnosis of AT is, for example, that you would prevent a long period of uncertainty towards the diagnosis. You could early start on with genetic counseling and future family planning for families, early cancer screening for parents as well, and you could ensure optimal clinical guidance from the start. However, on the other hand, there are people also saying, yes, that's true, but AT patients are actually asymptomatic at birth. So you would have loss of these golden years, as we call them, the years in which your child is actually asymptomatic, has no symptoms, and you don't have the knowledge that your child is sick. It's also a devastating news to hear in your maternity period, to hear that your child is not only sick, it will also have a decreased life expectancy, and that you will have an increased risk of cancer. It will also, of course, be accompanied by worries about the future, and some even stated, doesn't every child have a right to an open future? Well, this is what we as healthcare professionals actually thought, but there's actually a way more important group whose opinion should be taken into account in this discussion, and that's actually parents, because parents are actually the one who are being affected here. So we thought, well, parents are important key holders in newborn screening, and their opinion should be actually of great value in our policy making as well. So what we did is we created 2 questionnaires. One questionnaire for parents of AT patients in the Netherlands, and one questionnaire for parents of healthy newborns. So the parents of the AT patients, they actually got a short questionnaire in which we asked them, what do you think about an early diagnosis of AT, for example, for your child? It was sent to 64 families. We got a reply of, well, 55%, which is actually quite good. And on the other hand, we had the healthy newborn parents. They actually participated in the SONET study. We sent a more elaborated questionnaire out to 4,000 of these parents and got a response rate of 16.4%. So I would like to talk to you about the results. So the majority, we first start with the AT parents. So these are parents in the Netherlands of AT patients. And the majority of the AT patients actually did favor an early diagnosis. So what we did is we gave them 6 statements about early diagnosis of AT, and we asked them, do you agree or do you disagree, or do you not have an opinion about this? So first, as you can see, is 19 of these 35 parents would indeed have favored an early diagnosis of their own child. And the reasons they actually stated, as come forward in these statements, are to prevent indeed a long period of uncertainty, also to have early medical access, to take family planning into account, have early cancer screening for the carriers, and then there was a discussion about the happy years. And you can see not everybody is so clear about the happy years. So we asked, do you think that an early diagnosis of AT will actually withhold you these happy years that you had with your child? 15 parents said yes, that's indeed the case. However, 18 parents said, well, no, we don't think that there were any happy years, or otherwise maybe these happy years don't weigh up against the benefits of an early diagnosis. We had them in the final decision, we let them make a choice. Do you think that the advantages of an early diagnosis of AT actually outweigh the disadvantages? And as you can see, almost 3/4 of the parents indeed think that the advantages outweigh the disadvantages. And it's interesting to see what their decisive arguments were, so I will read them to you. So, this is actually what parents stated in an open box answer. We got the diagnosis AT when our child was 8 years old. The time before diagnosis was very insecure. We questioned what the future would look like, and this period was very difficult and sad. My child had also unnecessary diagnostic procedures, and these could have been prevented if an early diagnosis of AT was actually made. The diagnosis in my first child took actually a long time, and meanwhile she got a little sister who was then 6 months old at the time. The insecurity about her little sister was huge. If I had known this earlier, my first child would have been my only child. The risk was just too high for me. And then finally, this was actually one who was against early diagnosis of AT. In our case, an early diagnosis would lead to more years of worries and fear. We had 7 years without big worries, and those are very precious to me. So these were actually the conclusions of our AT patient cohort. So the majority of our AT patients did prefer an early diagnosis of the disease. And the main arguments mentioned were the insecurity in the diagnostic process and also family planning. But of course, the opinion of parents of AT is very valuable, but it might not reflect the general population of parents. And this is what we thought, well, okay, then we have to expand our questionnaire study into a new population of healthy parents. And that's what we did. So we actually invited these parents who participated in the SONET study to fill in this questionnaire. And we gave them a little bit of background information about AT, but not too much, just very precise. And then we started with 2 scenarios of 2 patients, Max and Lotte. And Max was a patient with a late diagnosis of AT, and Lotte was a patient with an early diagnosis of AT. And without any more information, we just asked the parents, what do you see in these 2 cases are the advantages, and what do you see as the disadvantages? And they could actually name several answers, so that's why the percentages are not adding up. But let's see what they said. So late diagnosis in the case of Max, as you can see here, is a disadvantage, is indeed that, or an advantage, let's start with that, is that you have a carefree period. So that's the happy years that we are talking about. However, a big percentage of parents, 26.2%, said that they actually did not see any advantages in this late diagnosis. Disadvantages they did see. They said, well, okay, it's again the family planning, and you also have a delayed start of surveillance. In the case of Lotte, who had an early diagnosis of AT, they said, well, she can start very timely with supportive measurements, such as physiotherapy, for example. And also, they appreciated the clarity, what to expect for the next years. Disadvantages, again, you don't have these happy years or these worry-free periods, and you're also unable to enjoy your maternity period. So we asked them, would you participate in newborn screening for AT if a test was available? So at this point, AT can only be found as a secondary screening to Skit, and not all AT patients can be found. So this was a question, a hypothetical question. And as you can see, 81% of the parents said yes or probably yes, while only 9% of the parents said no or probably no. And then we had 2 statements, and these 2 statements were actually included in both questionnaires. So it was included for the parents of AT patients and also included for the parents of healthy newborns. And the first statement was, all right, in the Netherlands we now have this situation. If you have an abnormal Skit screening result, you will not immediately do diagnostics for AT. We will monitor the child and we will wait, but only if symptoms of AT will occur, we will start with the diagnostics. And then we asked, do you agree with this policy? Well, as you can see, the majority of both groups actually disagreed with the policy that we are now currently running in the Netherlands. So that's actually very valuable information for us. And in the next statement, we asked them if a technique was available to detect all children with AT via newborn screening. AT should indeed be included in our newborn screening program. And again, as you can see, the majority of both groups actually agreed with this statement. So the conclusions here are actually that both parents of AT patients and also the parents of the healthy newborns would prefer an early diagnosis over a late diagnosis. And they would also prefer to have newborn screening for AT if that was an option. The main reasons that were actually mentioned here was the prevention of a long period of uncertainty, family planning, and also the ensurance of optimal clinical guidance from the start. So the majority of parents indeed would use a test for newborn screening for AT, but they also said that if a test was available, AT should be added to the newborn screening program. So as for a discussion, and I would also like to ask you some questions about this as well. So as you all know, reporting untreatable incidental findings actually still remains a disputed topic worldwide, and we are now engaging in this discussion. There's different perspective. Of course, we as healthcare professionals definitely have a different perspective from parents or patients or even clinicians. There's cultural and moral beliefs that probably also influence this decision-making process. And that's also why we are actually thinking that probably perspective of parents can actually even differ between countries. So if there's anybody here that would like to also engage in a questionnaire study, please contact me because we are more than welcome to share the questionnaire that we already have made with anybody who is willing. And I would like to end my talk with actually 3 questions to the audience. So I'm just going to ask you some questions, and let's do a raise of hands. Because I want to know, do you already screen for Skit in your country? So we're going to go with A, yes, Skit is fully implemented. Some over there, probably United States maybe. Yes, we have a pilot study or a pilot study planned, which is also, that's a bigger group, so that's actually very positive news. Almost, we are awaiting a governmental decision or governmental approval. Some as well. We've been there, it takes some time. Or D is just no. No screening, no pilots planned. Still some people in the audience have no pilots planned or no newborn screening for Skit, so hopefully that will change. Second question, if you have something like a pilot study, a planned pilot study, or anything else, what genetic follow-up is used in your country after an abnormal Skit result? So is that A, whole genome or whole exome sequencing? I see small, one hand over there, a couple of hands, yeah? All right, is it a PIT gene panel? More hands. Is it a Skit gene panel with the ATM gene? Also a couple of hands. Or is it, as in our case, a Skit gene panel without the ATM gene? That's probably the Dutch people. Yes. So then a question that you can answer either as your view as a clinician or even as your view as a parent. What genetic follow-up would you prefer after an abnormal Skit screening result? So would that be either whole exome or whole genome sequencing? No, not a lot of hands. A PIT panel? I think I would prefer a PIT panel, yeah. A Skit gene panel with the ATM gene? Some. Or as we are doing right now, a Skit gene panel without the ATM gene. So still some hands, so maybe we've convinced some people as well. So that's good to know. So as you can see, it's actually quite an interesting discussion. And this discussion is actually some that's only going to keep increasing because more and more countries are implementing newborn screening for Skit. And with this presentation, I would just like to emphasize that, well, indeed, take also the parents' perspective into account when making these decisions. And I hope that some of you will also join us in our questionnaire study as well. So finally, I would like to thank, of course, Miriam, but also the team from the Radboud University Medical Center. They actually helped us a lot in the contact with the AT patients, especially Michiel Schoenaker, who is also a PhD student. And I would like to thank you for your attention. And if there's any questions, I'm happy to answer them.